So it will slow it down, but it doesn't hold it permanently. That's the next step, rolling. So we have migration, and then it rolls down until it's at the site where it needs to cross. Then when it's at the site that it needs to be, it will maintain a firm grip. Okay? It maintains a firm grip, and then the next step is called adhesion. When it has that firm grip, it's adherent to the endothelium. No more stickiness, it's adherent. And then once it's adherent, the next step is called diapedesis. Okay? Diapedesis is the cell going through the basement membrane and in between the capillaries. That's diapedesis. Okay? Diapedesis. The neutrophil will secrete enzymes to degrade the basement membrane and squeeze in between, diapedesis. And then lastly, once it's in the extracellular matrix, it tends to be attracted by various chemotaxins. That's called chemotaxis. Okay? So those are the steps: migration, rolling, adhesion, diapedesis, and chemotaxis. That's how your white blood cells will escape the circulatory system and enter into the tissues. Okay? All right. And the escape of fluids can cause different types of conditions as well. We can classify the fluids based on the amount of protein. Okay? So if it has a high protein, that's called an exudate. Okay? If it's mostly fluid with low protein, that's a transudate. Okay? And the formation of excess fluid in the interstitial tissue is called edema. Okay? If you've ever seen pus, you've seen pus, it has that white color. If you like pop a pimple, that's pus. What gives it its white color are the white blood cells, as well as dead cells and bacteria. That's pus. Okay. Alright. Here's the edema, pitting edema. So you can see this sometimes in congestive heart failure. Pleural effusion, accumulation of fluid in the pleural cavities. Here's pus. All the different types. So here's again, this is the one I was looking for. Migration, rolling, adhesion, diapedesis, chemotaxis. Here it is. Oh, this is the one I was looking for. So these are the selectins and the P and E selectins, they hold it transiently. Okay? Whereas the more stable ones are here. ICAM. Okay? So, but I already mentioned that. Alright, next, removal. How does it remove the foreign substance? It's usually via phagocytosis. Okay? And the cells that are very good at phagocytosis will be your neutrophils and your monocytes and macrophages. Okay? So for acute inflammation, it's your neutrophils. Okay? They are the most numerous usually. They are usually the most numerous, except in newborns. But they are usually the most numerous white blood cells, and they respond quickly. Okay? Your monocytes and macrophages, they're more powerful than your neutrophils, but they're very slow to respond. So if you've ever seen cells at work, you see how powerful this macrophage is with her site. Okay? But they're much more white blood cells with their little kunai daggers. Okay, anyways, never mind. Phagocytosis, the steps: recognition, engulfment, and finally killing. It's done here. So it will engulf, it combines with vacuoles. Remember your lysosomes? Your lysosomes have digestive enzymes which will break apart a tissue, the cell that's been digested, and then finally excreted. That's phagocytosis. That's how they get rid of it. And then finally, regulation. How do you terminate the immune response? Because you don't want the immune response to go on forever. It must have a limit. So there are mediators that will inhibit the inflammation. You have anti-inflammatory cytokines. Okay. Most important are your regulatory T lymphocytes. Okay. And repair. How do you repair the broken tissue? With scar tissue. Or if it can do mitosis, you can replace the dead cells. Okay. So what are the outcomes of acute inflammation? You can have complete resolution, you can have scarring, or it goes worse downhill and goes to chronic inflammation. Okay? So talk about chronic inflammation and scar formation. So it's common in persistent infections, hypersensitivity, prolonged exposure to toxic agents. Okay. The only thing I want to show you here is two conditions. I don't want to go through everything. I will show you two conditions of excessive scarring. We have the hypertrophic scar and the keloid. It's very common actually here in the Philippines. This is usually genetics. So if your family is a keloid former, you are also most likely going to be a keloid former as well. So they're similar, but in keloid, the scarring is a little bit too much. It goes beyond the borders of what it should be. In hypertrophic scar, there's just an elevation. But in keloid, it goes way, way beyond the initial size of the scar. So let's show you the example. So here on the top left, we have a hypertrophic scar from an injury. So it's a little bit elevated. But in this one, the keloid, it's the site of the collagen is much bigger than the actual size of the initial scar. So that's the difference. But histologically, they're composed of collagen fibers, a lot of collagen fibers. Okay? So sometimes it's hard to treat this because if you remove it, you're making another scar, so it comes back. So usually what they do is sometimes they insert steroids to help dampen it. But it's not always effective. It's a thing. Not always effective. Sometimes it works, sometimes it isn't. So that's your keloid hypertrophic scar. This is what it looks like. You see very thick bundles of collagen. They're really thick. You can see them on low power. This is a scanning view. Look how thick these bundles of collagen fibers are. So that's a keloid. All right? Here's another one. This is the keloid on the left, and then the normal reticular layer of the dermis on the right. Notice the size of the collagen. This is the same magnification. Very big, thick, prominent than the normal. Okay, that's keloid. Alright. So what we have for inflammation, we have appendicitis. Yeah. Which of these is the appendix? The right or the left? Left? Right? Do you remember your history? What am I showing you on the left? Right here. Look at the arrangement of the lymphoid follicles. You'll notice on here, they're confined to one wall. That's Peyer's patch. Where do you find Peyer's patch? Ileum, mostly the ileum. Ileum is the best example. But sometimes they can go a little beyond the ileum. But you compare it to the other one, the lymphoid follicles are going everywhere. They're surrounding the entire lumen. This is the appendix on the left, the right side, the right side. Okay, so always don't forget your histo because you might struggle in patho, especially since some of our slides are not so good. Which one's the appendix? Right? Then what's on the left?
The right eye, right eye.
Something in the reproductive. What's the lining epithelium on the left side?
Dili na seminal yun.
Stratified squamous. You already forgot the esophagus? Please review your histo.
Oo, kay stratified
How are you
squamous,
supposed
boy.
to know these things if you don't even know the normal? So this is stratified squamous. This is the esophagus. Here are the lymphoid follicles. There are the crypts of Librucum. Okay, so review your histo. Fine.
Depende
So,
mo
what do we
sa
see in
kung i-zoom or
appendicitis?
dili, boy.
Actually, there's a lot of different types of appendicitis. Sometimes they classify it acute suppurative, and then acute gangrenous, then ruptured. The earliest sign of appendicitis is you get dilation of the blood vessels. Okay? Very prominent. You see that on the lower left side. And then in more advanced cases, you get to see fibrinopurulent material, which is pus. That's pus. That's the white stuff. coming out. Okay? And if you do a cross section, you might see ulcerations. See the mucosa where it's ulcerating here at the bottom? So that's what you can see grossly. What are the causes of appendicitis? Usually the most common cause that we get for appendicitis is due to a fecal lymph. It's kind of a very hard piece of poop that becomes like a stone, and it gets stuck in the lumen, and it compromises the blood flow. That's the most common. Other cases, it could be worms. I've had, ascaris. I've had ascaris one, appendicitis. So there are, and sometimes it could also be very enlarged lymphoid follicles, but usually there's an obstruction to the lumen. Okay. So take a look at this picture in low power. Notice what happened to the mucosa. It's gone. Some of it is just ulcer. There's no more mucosa in some area. There's a little viable area here, but this area is gone. So that area has been ulcerated. Okay? But to make a diagnosis of appendicitis based on Robbins, is what you need to do is look at the muscularis propria. And to make the diagnosis of acute appendicitis, you need the presence of neutrophils within the muscularis propria. You see the neutrophils here? The one with the little irregular nucleus, because remember, neutrophils are segmented. Their nucleus are not round. They have usually 3 to 4 segments. So I know it's really hard because they're small, but those are all neutrophils. So, and you know, the muscularis propria is not supposed to have neutrophils. It's supposed to only be smooth muscles, or smooth muscles and some connective tissue. But having that, that's a sign of acute appendicitis. Okay? That's the minimum requirement. Okay? Here it is. So the diagnosis of acute appendicitis requires neutrophilic infiltration to the muscularis propria. It's to the muscularis propria. Okay? Here's another acute appendicitis. Okay? We see another large ulcerated area here. Okay? We have a lot of appendicitis in the lab. Again, neutrophils present in the muscularis propria. We also have acute inflammation. We have abscess formation. So abscess is a type of liquefactive necrosis. It's liquidy. So here we have an example, one of an abscess somewhere. If you look at it grossly, it appears as this purulent, white, cheesy sometimes, well not really cheesy, but it's liquidy, semi-liquidy. And if you look at it in the microscope, what you see are mostly neutrophils. Okay? There's no architecture because it's not coagulative necrosis, but you see just a bunch of neutrophils. So here's what it looks like. So this is an abscess. All of those cells that you're seeing are neutrophils. And the pink stuff are the seroproteinaceous fluid from the blood. Okay? So that's liquefactive necrosis, or it's a pus, or an abscess, you can call it. Then for chronic inflammation, you know what organ this is? It is a gallbladder. What layer is missing in the gallbladder? Submucosa. Okay, so this is a normal gallbladder. Okay, so what's the predominant cell in chronic inflammation? You know? Mononuclears, lymphocytes and monocytes. Okay. As opposed to acute, it's neutrophils. Okay. So here we have the gallbladder. This is one that was actually removed due to stones, gallstones, cholelithiasis. So in this case, you'll notice that the wall is a little bit thicker than what it should be. Okay, it's kind of thick. It's not supposed to be that thick. And the mucosa has been kind of eroded. There are areas of hemorrhage and ulceration. Because when you look at it in a gross, it's supposed to be like velvety. It's actually velvety. I know it doesn't do it justice, but here's the hemorrhagic area, and it doesn't have that velvety texture appearance. So that's it here. Here's one with the actual stones. There are 2 types of stones. You have your pigmented stones and your cholesterol stones. You don't need to know that yet. Later on. All right, so this is what I want to show you. Look at the lamina propria. What's predominating in the lamina propria are usually lymphocytes. They're not neutrophils this time. We see lymphocytes, and maybe we even see a few plasma cells here. as well. So chronic inflammation, lymphocytes, and macrophages. There is something that you can see in chronic cholecystitis. This structure here, do you know what structure that is? Oh wow, I'm impressed. Rokitansky-Ashcroft sinuses is correct. So what actually happens, it's kind of like an invagination of the mucosa. Do not confuse that with cancer. That's not cancer. It's just kind of like herniating. That's what's happening. Rokitansky-Ashcroft sinuses. That came out on the exam and I couldn't spell it properly. So I got it wrong. Maybe you guys will be better at spelling than me. Alright, we still have next gastric ulcer for chronic. Okay. We won't go into too much detail with this because actually this is also my topic in the digestive system. I just want you to be able to identify that it's an ulcer. And maybe if you can identify the layers. Okay? So here we have the stomach. So up in the upper portion, we see the ulcer, the area that has no more epithelium lining. Okay? So usually the most common cause of ulcers, there are two most common causes of ulcers, chronic NSAID use and H. pylori. Those are the ones that are very associated with these peptic ulcer disease. So in regards to the layers, the very surface consists of necrotic material. That's dead cells. It's all dead cells up here. Then in the next layer, you have your granulation tissue. So granulation tissue is kind of like the tissue trying to repair itself. So what you're going to see is, you'll see formation of new blood vessels. So you can see these blood vessels that are going up. They're trying to rebuild the tissue. That's granulation tissue. So like if you ever have a scab and then you pick off the scab, you see that pink tissue underneath it? That's granulation tissue. And that's the same here underneath the dead cells, granulation tissue. So expect to see a lot of blood vessels. And then underneath that, you have the area of repair or collagen scar formation, which is not really seen very well here because it's at the very bottom. But you see collagen, that's the scar, the formation. So those are the layers. We do have some good slides for granulation tissue or peptic ulcer disease in the lab. Okay. All right, this is the last chapter. Yeah, I know I'm tired too. Actually, I started giving up on this portion because I got tired. So I only focused only on what's in the lab, so I don't want to cover hemodynamics, plus I really don't like hemodynamics. All right, so what we have is in the lab is chronic passive congestion. But if you want to actually read chronic passive congestion, it's actually in chapter 18, because that's the one. In this disease, we're talking about the liver. Okay? But it's discussed here because we're talking about blood flow, okay, and hemodynamics. So the actual text, though, you have to go to the digestive system. So try to also read briefly on those chapters, okay? So what happens in chronic passive congestion? Okay? This refers to congestion of the blood vessels in the liver. And the most common cause of that is usually heart failure, be it left-sided heart failure or right-sided heart failure. Okay? So let's take a look. So if the right side of your heart is not pumping correctly, that means the blood will flow black, okay, and it will stagnate in the portal systems of the liver in the blood because it can't pump it properly. If your right side of the heart is failing, it's not going to be able to move much blood, so it just stagnates in the liver usually, because that's where lots of the blood comes from. Okay? So, review again histology. I already reviewed it, you don't need to review it. But I do want to show you the zones. Do you remember the zones? Zone 1, how many zones do we have? Of course, because that's what's shown in the picture. 3 zones. And how do we classify these zones? The one closest to the portal triad is zone 1. And then the one closest to the central portion, or the central vein, is zone 3. So this zone 3 is also known as central lobular area. Center of the lobule, the hepatic lobule. So these zones are actually important because the zones have different oxygenation and nutrition Okay? Which of these zones is the most oxygenated? Zone 1. And the least would be zone 3. So if there is congestion, which site do you think would be damaged first? Zone 3, because they have less oxygen and less nutrients. So when you see early phases of passive congestion, it's only the central portion that gets damaged. The other areas, zone 1 and 2, are still usually viable up until a point until it gets really bad. So this type of necrosis is very interesting, where the center portions are necrotic and the peripherals are usually still viable. It gives us this pattern. And this pattern is known as the nutmeg liver. Have you ever seen a nutmeg? It's okay, I've never seen one too. I only see it on those Starbucks in the picture of the nutmeg. You ever see that in Starbucks, that powdery stuff that you add? I don't know, does anyone like nutmeg? What does it taste like? Well, if you don't know, it looks like this. So, see the nutmeg pattern? In the nutmeg, you're supposed to ground it. Right? So, it does kind of look like the nutmeg pattern. So, what you look at it here, if you go back. So, the dark pink areas still represent viable liver tissue. Okay? That's your zones 1 and 2. Whereas the yellow pale areas are your necrotic areas by the central veins. That's why it has that nutmeg pattern. Okay. So here's what it looks like. It's kind of hard to imagine. So we see the viable liver here. Okay. But in early stages, what you see is the sinusoids are much bigger than what they should be because they're stagnating. Okay? The blood's not pumping, so what happens? They're just pooling in the sinusoids. So you'll see dilation and congestion of the blood vessels, which are more pronounced in the central lobular area. Okay? So that's what you see here. So right now, this is a very early case. So in early cases, it's sometimes hard to make a diagnosis. In more advanced cases, so you begin to start to see injury of the hepatocytes. Okay? The hepatocytes are bigger than they what should be. Remember, the hepatic plates are usually only 1 to 2 or 2 to 3 cell layers thick. And if you look at the size, they're getting a little bit bigger, meaning they're getting injured. Okay, that's a site of reversible injury, cellular swelling. Okay, that's cellular swelling. Okay. Now you begin to see in the later stages, these white spaces represent the central vein. Okay? And if you look around the central vein, you see all the blood stagnating here around it. But if you look at here, here's a portion of the portal triad, they're still viable around it. Okay? So this is now, you're starting to begin to see how the nutmeg pattern is beginning to be formed there. Right? So that's now central lobular hemorrhagic necrosis. And if we do special staining with Mason stain or looking for any type of collagen stain, you begin to notice that collagen are starting to form. This is the chicken wire appearance of collagen, chicken wire. The chicken wire is that little wired fence that you use to secure your chickens. I don't know. But it looks like that. It's like little network. So, but this is only seen with the collagen stains. Okay? And then when it gets really bad, what happens? You get ridging necrosis and ultimately cirrhosis. Cirrhosis is once the liver has a lot of fibers. Liver cirrhosis. Well, in this case, it would be called cardiac cirrhosis. Anyways. And then here, we have more. The only viable areas are near the zones, but we have necrotic areas. Okay? It's really blurry in this picture. It's not blurry on my iPhone. Alright. And then the other one we have is pulmonary edema. Okay? So this is excessive interstitial fluid in the alveoli. And they're classified as either hemodynamic or non-hemodynamic causes. Okay? We'll only focus on hemodynamic causes. Okay? Usually due to increased hydrostatic pressure, so more pressure pushing blood out of the cell, out of the blood vessel, as opposed to oncotic pressure, which is due to the albumin retaining the pressure. So here's the diagram. Usually they are gravity dependent because that's where the hydrostatic pressure is greatest. You'll see fluid accumulating within the alveoli. You can see this in, again, heart failure. Okay? More on this time, usually the other side, left side in heart failure, because that's coming from the lungs. If you can't pump it out of the lungs, then it stagnates there. But also the other side, if you get one side heart failure, usually it results in the other side also becoming failing as well. So they eventually become hand in hand. Alright, so microscopic, the capillaries are engorged because again, it can't fit, the heart cannot pump it properly, so capillaries are engorged. And what they always ask on the exam are heart failure cells. Although they are called heart failure cells, they're not actually found in the heart. They are found in the lungs. And what do these represent? They're actually your alveolar macrophages that have eaten the blood cells. And then as they digest it, they make hemosiderin. That's the pigment of digested blood. Not to be confused with lipofuscin. It's hemosiderin. Okay? So let's take a look at that. This is a normal lung. So do you remember your structures? You have your, is it a bronchus, bronchial? Bronchus. There's no cartilage. So bronchioles. So it's supposed to be first your terminal, then you have your respiratory, then you have your alveolar ducts. So at least you know that. So that's a normal. Let's look here. Oh, what happened to the alveoli here? They have this pink flood, pink stuff. That pink stuff is fluid, okay? Things that have been leaking from your blood. And look at the blood vessels. They're really full and like they're congested. There's a lot of blood cells that are packed in there. But what's predominant is